Hi everyone, it's a concerned Dr. Miskoff, May 22nd, about 8:15 p.m. I hope everybody's doing well and staying safe. A lot of people getting their antibodies tested now. Hospitals, some of them requiring it, and those who are doing obviously procedures that are higher risk. So I had my antibodies checked at the end of April. Supposed to get them checked now per the hospital system in May. So I'll be going for a second round, although I feel like it's a little early as I just went just over 2 weeks ago and had IgGs that were negative. They are, as I'm told, doing IgGs. I at some point want to go to LabCorp and get the triple IgM, IgA, IgG. They're also offering apparently a new nasal swab where they don't go as deep, but they hit more towards the outer part of the nair or just inside the nairs, and so less invasive, but hitting both sides. And so that's as well being offered again to healthcare providers in the system. So I do plan on going this month, and I anticipate if I was negative 2.5 weeks ago, obviously a high probability of still being negative. And it'll be curious to see what healthcare frontline workers in New Jersey, at least central Jersey, what their positivity rate is for antibodies. I'm anticipating, just talking to people that have had them done, which is pretty low rate. Really just have met a few people that have had them, a couple stories. Okay, yeah, I had COVID-19 and the antibodies were negative, and I've heard that a few times. But I'm going to anticipate somewhere in the 10 to 20% zone for healthcare providers. They're saying throughout the country, on average, just about 7 to 10%. These are early numbers. And then you can find pockets where it's over 50% in some areas. Remember, the Bronx was, I think, over a third. So, different boroughs and different high populous areas. As far as treatment goes, another study came out with hydroxychloroquine looking at over 600 hospitals. I believe Dr. Patel was involved in that one. And in this study, again, this is not a prospective double-blind randomized trial, but although it was, massive numbers looking at huge amounts of hospitalized patients who received hydroxychloroquine or chloroquine, Plaquenil, and in fact, there was no benefit in these patients. If anything, there was an increased risk of cardiac arrhythmias and death. And those who received macrolides or azithromycin had even a further increased risk. So that article, you can look at that in the Lancet. Most of these journal articles are now available for view without even paid subscriptions, so you can just Google that and check it out. But this doesn't tell us anything about the outpatient scenario. We're still waiting for more data on prophylaxis studies, those who were exposed to patients with COVID-19 or healthcare providers that are exposed, and there are some around the world studies in regards to that. And I'll be curious to see if there's any prophylactic benefit, although suspicion is that it may not be as strong as initially suspected. Again, this is not an antiviral. It may have some antiviral properties, at least in vitro, but it doesn't seem to be panning out overall. We all know that President Trump had announced that he's taking it. I won't get political. He did have some recent exposure. I can tell you personally, I've had many exposures, and I personally am not taking anything like hydroxychloroquine, only the supplements that I've mentioned on previous vlogs. So it looks like for now, and probably forever, hydroxychloroquine's out in the hospitalized patients. Outpatient, I'm certainly not recommending it until we have further data, even for prophylaxis. Remdesivir, new study published just today, actually. And this one is by John Beagle et al. This is from the ACTT1 study group. Can't see it on the screen, but it's Remdesivir for the treatment of COVID-19. The preliminary report from the New England Journal of Medicine, hot off the press. This data was recently released, at least mentioned, which is what led to the emergency authorization when there was a reduced recovery time. Again, nothing spectacular, but they were looking at a difference of median of 11 days of recovery versus 15 days of recovery for those who did not receive Remdesivir in this placebo-controlled look at 1,063 patients in a 10-day treatment. So in general, is it good that these patients recovered in 4 less days? Yes, that's good, but again, is that enough to change the game? I've suggested in the Silver Bullet vlog recently, maybe this is the silver bullet. This is not enough data to make that claim at this point in time. Again, if you were able to put this in a pill and give it to patients outside, like Tamiflu outpatients, immediately upon developing symptoms, and if testing was available, for everyone immediately, and you could figure that out, could it have a Tamiflu effect like Tamiflu has on influenza? We don't know that yet. I can tell you from this study, every single group of patients that was looked at, and the average age was hitting just under 60. There was about 60-ish, 65% male, as we've seen in many other studies, a male predominance. Obesity, hypertension, diabetes seem to be the risk factors that were involved. But no matter what group you looked at, whether it be in about 25% Hispanic, about 28% Black, 50% white, and the rest Asian and other nationalities was the breakdown, again in this New England Journal article. But no matter what group you looked at, all of them did better who received Remdesivir in regards to that outcome, again, of recovery time, which is not mortality, it's not ventilator days, it's not ICU stay. So we'll need more data to see if there's benefit in those regards. But every single group did better except for one, and that was those who received ECMO, extracorporeal membrane oxygenation, again, a bypass type device for directly oxygenating these patients' blood when they can't, and the ventilators failing. We know that the mortality rate is mostly over 50%, sometimes 80, 90% in some cohorts. So it's not a surprise that that was the group that Remdesivir didn't help, especially in regards to recovery time, when the recovery time when you go on ECMO, when such a high death rate is often a month or greater. So Plaquenil's out in the most recent study for inpatients. Remdesivir is still in. Happy to report that Gilead did donate the doses as promised in our hospital at least, and I've heard multiple, if not most hospitals have received enough doses to give those acute patients coming in the door before they hit the ICU, before they hit the ventilator. We have over 400 doses as of today to still give. We're actively giving it with good anecdote, at least the ones I've treated so far, so there's comfort there. Again, this data didn't look at per se that specific group of more viable patients. I'm not talking about the 90-plus-year-old from the nursing home with dementia, no quality of life. I'm talking about everybody else for the most part, even with one or two comorbidities. The hope here is that if we can give this extremely early, and if Gilead can come out with a pill form that we can give even earlier, that we will see studies that show even better benefit. With that said, in this study from New England Journal, there was no benefit in the group who had symptoms under 10 days versus those who had symptoms greater than 10 days, and that was slightly discouraging when I saw that. But again, every group did better, especially that under 40-year age group, as would be expected. Anti-IL-6 update, Sarilumab trial, we were doing that with a placebo arm, and these patients were randomized. That seems to be locked at this point, so if you want an anti-IL-6, we're giving tocilizumab or Actemra. Again, some caution with early use of these medications. Sarilumab seemed to have a signal where the more sick or later on patient did better than the patient who was less sick. And maybe they need their interleukin-6 up front. There is some suggestion that if you suppress IL-6 too early, that the virus can accelerate its replication. So maybe having your immune system fight initially isn't the worst thing in the world, rather than shutting it down so soon. And the story with steroids, similar, less expensive, obviously, to suppress the immune system with a steroid. But is it risky? Is it not? I've been using some in patients. For example, if you had again a 90-year-old or an 85-year-old with dementia from a nursing home who you're concerned about giving a powerful anti-IL-6, maybe that's a patient you would trial steroids in. Still trying to figure that out, and I think more studies will help in the future as where exactly to use the anti-IL-6, whether to use a steroid with it, without it, what's the risk, and that's interesting. Just back to the Remdesivir trial, the safety was actually extremely good, and I believe actually the placebo arm had a higher incidence of more severe events than even the Remdesivir. So at least the safety seems to be there, and that's not a big surprise. Quickly on anticoagulation, again, we are using Lovenox and enoxaparin in most patients. The subcutaneous shorter-acting heparin products and those with renal failures. I still wonder if we should give heparin drips to all patients admitted, not all, but most patients admitted through the ER, sort of stratifying them to a lower or moderate dose versus a high intensity, depending on where they are clinically, where their D-dimer is, what's their oxygen requirement, and what does their X-ray and imaging look like. So we'll see how that pans out. Is aspirin play a role? Is it really just for discharge? Will we be using a cocktail of anticoagulants, aspirins, Eliquis, Xareltos, Pradaxas, the DOACs? Hard to tell, but for now, we are hitting patients with subcutaneous Lovenox, at least in our system. Most of us are utilizing that at a 40 milligram dose. If they're not doing well clinically or the D-dimer is higher, we're giving therapeutic doses, and some are choosing a sort of in-between 40 twice a day for that more intermediate patient who may be sort of stabilized but still quite sick. More to come on anticoagulation. Plasma, thanks to the community, as mentioned before, seems to be plenty of it to give, and they all seem to be getting it, at least the ones that I've recommended it for. Haven't heard of anybody not having it available. So there seems to be quite an ample supply, at least locally, for plasma, thanks to a robust donations from the community and quite a bit, as I said. Plaquenil's out for the inpatient, probably not going to show much benefit for outpatient, but the data is still pending. Jury on that for the prophylaxis zone. Remdesivir seems to be our best bet right now. Early on, if you can get it at your system, Gilead has kept to their word, and we got it. I thought we were going to have to wait till closer to June, but in fact they did deliver, and then they delivered more. They did report that they're going to start charging in July. I saw that in the press release. But for now, I would try and give the Remdesivir as early as possible inpatient and hope for an outpatient version by next season. Plasma early as you can seems to be the way to go as you're sort of ordering the Remdesivir. We may give plasma to patients who are even less sick, but again, the patients that are getting admitted typically fall in that moderate to severe category, or they're out of the hospital very, very quickly. And then anticoagulation, of course, steroids maybe, and anti-IL-6 if they're progressing, but saving it for that more moderate to severe progression. Well, I think we'll call it there. Everybody stay safe, be well, and we will see you again. Have a great night, a great weekend, and Memorial Weekend, and thank you to and special, obviously, thanks to our veterans. This isn't Veterans Day; it's Memorial Day. To those who paid the ultimate price, lost their life, to their families. God bless everybody, and have a great night.